Hello everyone, this is Mike Gallo, and this is my presentation topic. Okay, so part of the problem here is that CLABIs, which are central line associated blood infections, are a hospital-acquired infection, which are not covered by insurance. The hospital eats up the cost. In 2011, the CDC estimated that about 10 to 25% of patients would develop a hospital-acquired infection. Now, what a CLABSI is, like I said, it's an HAI, but it pertains to central venous access device. And in this research paper, I'm focusing solely on ports and PICC lines. It happens when they become colonized in one way or another with the pathogen. The Joint Commission in 2012 said that, in general, HAIs increase costs, length of stay, and a significant risk of morbidity and mortality in patients. And in 2001, there were 1.7 million hospital-acquired infections and 99,000 associated deaths. So it's estimated that CLABSIs is definitely one of the highest causes of death among all of the hospital-acquired infections. It has a mortality rate of 15 to 25%. It counts to 2,500,000 hospital-acquired infections per year. It increases a patient's length of stay by 3 weeks on average because they often need IV antibiotics and or need to remove the central venous access device, especially if it's a port. That can be more of an issue. Individual treatment for CLABSI infection can range anywhere from $3,700 to $36,441. So it's a very costly hospital-acquired infection as well. Between 2001 and 2009, the U.S. did see a decrease of 58% in CLABSI rates, which did save a significant amount of money. You could see by the Douglas article. And newer research by O'Neill in 2016 found that there was a 46% decrease between 2008 and 2013, which may have saved up to 6,000 lives. And I think this one is pretty self-explanatory. So CLABSIs have been around as long as central venous access devices have been around. However, in about 1999, the CDC recognized that CLABSIs were becoming a health crisis, and they were increasing at an alarming rate, and therefore driving up the cost of healthcare. So the CDC then put a budget towards education and prevention of CLABSIs and maintenance of CVADs. They started with the initial spending budget of $586 million, which then increased every year. In 2009, it was $862 million that they spent, and they've spent approximately $2 billion since 2001. The Institute of Healthcare Improvement and other groups, such as the CDC and the Joint Commission, determined that CVAD bundles, assessments, maintenance, documentation of nurses was subpar, and they determined that nursing had not completely everything to do with CLABSIs, but they were a significant risk factor in them. Now, why are CLABSIs such a problem? You're probably asking. Well, it's because there's so many of them. In the U.S., there's about 3 million CVADs used inpatient adult hospital settings each year. There's also 50 million CVAD days. That's to say the number of days a patient has a CVAD accessed. If a patient has more than one CVAD access, that will count for more than 1 day. According to New York State Department of Health, which is where I live in New York State, MICUs average 1.2 lines per day, 1,000 days, excuse me. SICUs average 0.91 per 1,000 line days, so on and so forth. However, the most alarming thing here is what's in red, is that the MICUs report 48.5%, SICUs report 49.7%, and medical surgical unit floors only report 10.5% of device usage. Now, if you have a device such as a CVAD in place that's not in use, that's just risk for infection for absolutely no reason. So nursing needs to be more diligent about talking to providers to get a CVAD pulled or deaccessed if there's really no need for it. CLABSIs are taken so seriously and are so big of a problem that actually the Hospital National Patient Safety Goals of 2011 implemented 13 recommendations specifically to CLABSI reduction and CVAD best practices. There's 13 recommendations, most of which are within the RN scope of practice, and there's a link there if you'd like to see those. So how do CLABSIs occur? What's the mechanism? It's actually multifactorial. Basically, all it is the growth and colonization of a bacteria or pathogen or pathogens at the site of the central line. That enters the bloodstream, causes a blood infection, such as sepsis. They can occur in many different fashions. Most common are intrinsic, extrinsic factors, as well as extraluminal contamination and intraluminal contamination. So intrinsic factors are non-modifiable, such as the patient's age, their immune status, underlying acute illness or chronic diseases, immunocompromised, such as those with HIV or bone marrow or organ status post organ or bone marrow transplant, any various diseases of the white blood cells, such as neutropenia. Extrinsic are huge because they can be modifiable. One of the biggest right here is when a CVAD is in place longer than it needs to be. Other ones are prolonged hospitalization, receiving TPN through a CVAD, patients that have multiple CVADs in place, and those that have CVAD in place without appropriate indication. Also, it's important to note that CVADs in femoral or jugular veins are more prone to CLABSIs as well. Extraluminal contamination, that typically happens when the CVAD is inserted, so usually that's on the provider's behalf. However, if a nurse is accessing a port, if he or she is not following the proper sterilization CVAD bundle techniques while accessing the port, that can definitely cause an infection. Intraluminal contamination is definitely, on the nurse's aspect of care. That occurs when microorganisms or pathogens are introduced into the catheter lumen. The connector hub is manipulated. There's improper sterilization when you go to use the lumen, or there can be some kind of contamination within the fluid and or tubing that the catheter or CVAD is connected to. So what is the CVAD bundle? It's basically a way to reduce the risk factors we just talked about. All of the components of the bundle are recommended by the CDC, IHI, and Joint Commission, among other groups. And I'm not going to read you all of the slides, but all of those need to be completed for a successful 100% compliant CVAD bundle, including the documentation that goes into the computer to prove that the CVAD bundle was done and completed. So for my PICO, I have adult patients that are in hospitalized settings with a CVAD device. I have limited to peripherally inserted central line catheters, PICs, and or ports, just to limit this study. Interventions were based on the most recent literature that I could find that had anything to do with nursing compliance with CVAD bundles, that also included educational in-services, competencies, as well as auditing and monitoring of nursing compliance with the bundles. We'll compare these to previous compliance rates pre and post intervention, and the outcomes I have is a short term for nurses to improve their CVAD bundles, and the long-term outcome is to see a decrease in CLABSI rate on a quarterly basis in patients. This is the first study. It's a level 2A. It's a quasi-experimental study conducted by O'Neill et al. Basically, what this study did was it took 8 different units of a hospital, 4 wards had the intervention, which is described here. It's basically all education, and 4 wards with similar patient population did not receive the education. As you can see in the chart, the intervention ward performed significantly better in all areas. In areas where you can see as in column 2, where both have significant findings, the intervention ward had a more significant finding. So that does prove that the bundle does work. Education does work to help improve CVAD bundle compliance. Here I have a non-experimental level 3A study that basically is just, there was an intervention on in-service about proper CVAD bundle documentation. And as nurses, even with one element of the 5 described prior documented, there showed a statistically significant decrease in CLABSI rates. So the nursing compliance, as they comply more with the CVAD bundle, the more significant CLABSI rates decreased, except for 2 out of 5 elements. Although that's significantly statistically significant, that's an oddball. But the more elements of the CVAD bundle that are performed and documented, the more statistically significant decrease in CLABSI rates. Another research article I used was by Tang et al., 2014 non-experimental study. So it was done over 10 months at 5 different teaching hospitals. The goal was to increase CVAD bundle rates and decrease the lines per 1,000 line days. The intervention included educational services for all staff, including doctors and nurses. They watched 3 different videos. The first was on proper CVAD insertion and education, more geared towards the provider end. And the second and third videos were more geared toward the bedside end of, focusing on techniques and components of the CVAD bundle, such as assessing the site, cleansing with alcohol and chlorhexidine, putting on a proper clean dressing, monitoring the dressing, changing dressings and tubing and valves as needed. The third video focused on monitoring and surveillance of nursing performing CVAD bundles. That intervention was compared to 10 months prior, 2 years and 1 year prior during the same exact dates that the intervention took place. And what they found was a statistically significant increase in CVAD bundle compliance by nurses, as well as a significant decrease in CLABSI rates. There was also a decrease in the number of catheter per patient days, although that was not found to be statistically significant. In this article by Morrison, Raphael, and Brenneman, 2017, it's a level 3A, 14 units were selected, and nurses on these units, there were 487 that managed the CVAD 90% of the time were included. They were basically just given education, policy, procedure updates, including CVAD bundles, and then there were expert nurses, CVAD and PIC nurses, who would monitor and audit the 487 nurses at least once a week over 16 weeks, performing all the components of the CVAD bundle, which has been previously mentioned, and documentation pertaining to the CVAD bundle, such as site assessment, dressing, clean, dry, intact, is it peeling, etc. If any nurse missed a component of the CVAD bundle, they were given remediation. It was non-punitive. They were given report cards also so they could monitor their progress. The comparison was pre-intervention and during the intervention, and it was found that after the 16-week trial, there was an overall statistically significant improvement in nursing compliance. And also CLABSI rates decreased by 55.56% from the year prior, although it was not indicated in the article if it was significant or not. So the intervention I'm proposing is going to be taking place at a Central New York large facility in September of 2017. It's going to combine clinical nurse educator as well as nurses and nurse managers and nurse coordinators. It will consist of kind of a combination of everything I've already talked about. So there'll be an online in-service where the nurses will access something at the hospital called HealthStream, which is where they do their in-services. They'll monitor videos on CVAD bundles and maintenance, as well as demonstrating the correct methods of performing a CVAD bundle, such as in the Tang article. They will also be required to take an online skill test, an assessment exam, in order and pass with an 85%, which is something that O'Neill did. And 3 through 6 are pretty self-explanatory. They'll be monitored. They will also receive, they'll be monitored doing a bundle, as well as their documentation to the bundle. They'll be also required to do annual competencies to make sure that they're up to date, and they'll be allowed any one-on-one teaching that they need in order to improve their skill set. So for barriers, we have nurses have a lack of time to complete all tasks during shifts, and CVAD bundle could be passed on to the next shift. Facilitators such as the clinical nurse educator, nurse unit manager, and RN coordinator can make sure that these things are being documented every shift through electronic medical record. It's easy to pull reports. Nurse staff ratios is always going to be a problem. However, since we are doing most of this online, nurses can get around not having to make a specific time and date to do the in-service. Getting nurses to watch the in-service if they're not interested in this, they will have to take a post-test, so that will encourage them to actually watch the material. Nurses tend to be disinterested in things that they're not seeing much of a change in or any progress from, but it's important to educate the nurses also that if we decrease CLABIs, if we increase CVAD compliance to decrease CLABIs, that will profit the hospital more and also increase the frequency of and amount of pay raises or bonuses. So facilitators, we have, as I mentioned, the first 3, and we also have the RN who may want that raise. So for some measurable outcomes, we will monitor the CVAD bundle compliance, the nurse actually doing it at the bedside as well as their documentation, at least once a week. The outcome goal is to have all nurses become and remain compliant by week 12 post-intervention. They'll also have the report cards to show improvement over the week, days, etc. And also the nurse managers can be aware. Weekly monitoring of documentation will also continue after intervention. Again, the nurse manager can just pull a report, and weekly auditing may continue as long as needed if it's discovered by week 12 that, we're not at 100% compliance or nowhere near it. The long-term goal is to, after we get the nurses compliant with CVAD bundles, is to have nurse managers to continue to report CLABSI infections to infectious disease. Infectious disease can then monitor the CLABSI rates, patient data, and nursing documentation, where the patient has been in the hospital, to introduce any other causative factors that may not be related exactly to nursing. But if it is a nursing error, they can absolutely bring that up. So we would want to compare the CLABSI rate to the pre-intervention rate while the 12-week of intervention, and then monitor it monthly, and hopefully we'll see a decrease in percentage of CLABSIs in patients with a CVAD. And the goal would be to reach 0 within 12 months post-intervention, which is what most hospitals are doing these days.